Welcome to Managing Depression in the Workplace, Bridging Research and Practice. This webinar is co-presented by the Canadian Mental Health Association. Thank you for joining us today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be co-moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program, through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website along with the slides. You will be emailed the direct links for all of these items when they're available. Today's webinar will be co-moderated by Jordan Friesen, National Director, Workplace Mental Health at the Canadian Mental Health Association, and I will let him introduce our speaker, Dr. Dwayne Van Eerd. Dwayne and Jordan, welcome. Thank you so much for making the time to be with us today, and I will hand it over to you, Jordan.
Thank you very much, Yusra, and welcome to everybody joining us from across the country. My name is Jordan Friesen. I'm the National Director for Workplace Mental Health with the Canadian Mental Health Association. Just for context, the Canadian Mental Health Association is Canada's oldest and largest, most extensive established mental health charity. We've been around for just over 100 years with a presence in 330 plus communities across the country. I am very pleased to be here today, both to moderate and also to learn from Dwayne Van Eerd from the Institute for Work and Health. And let me just set the stage for what Dwayne is going to be talking about. And in particular, we're going to be focusing on research and practice-based evidence to support employees with depression in the workplace. Now, this is significant for employees as well as employers for a number of reasons. One, of course, because as many of you probably know, depression is, according to the World Health Organization, the leading cause of disability worldwide. According to Canadian census data, it's also the most common mental health condition reported by workers in Canada. And it contributes to that large $51 billion that poor mental health is costing Canada's economy every year. We also know that depression is a strong predictor of presenteeism, which is estimated to be a large chunk of that $51 billion cost. And from my personal and professional experience in the field of mental health, I also know that depression carries a very significant functional impact. This is also one of the most challenging areas that employers come to CMHA for, specifically from an HR function, is to understand how can they best support employees, frankly, that are experiencing any mental illness, but primarily focused in on depression, because we know it is quite common within Canadian workers. So for that reason, I am very excited to hear and learn from Dwayne today. So a little bit about Dwayne, and Dwayne can feel free to correct anything that I say, but Dwayne Van Eerd is a scientist at the Institute for Work and Health, where he's been a researcher since 1997. He has a bachelor and master's degree in kinesiology from the University of Waterloo, a Master of Science in Health Research Methodology from McMaster, and a PhD in Work and Health from the Faculty of Applied Health Sciences, also at the University of Waterloo. After getting his master's in kinesiology, Dwayne got his start in occupational health and safety research in a clinical setting, studying musculoskeletal disorders in performing artists. Now a scientist with the Institute for Work and Health, he focuses on prevention of work-related injuries and disorders. His research projects have included evaluations of participatory organizational change programs and training interventions, as well as systematic reviews of the prevention literature. Recent projects including synthesizing practice evidence with research evidence for better practices in mental health and musculoskeletal disorders. Dwayne, welcome, and we are very excited to hear what you have to share with us today.
Thank you, Jordan and Yusra, for that lovely introduction and all that detail. I'm very pleased to be here to talk about this research project and the resulting guide in the hopes that there will be some practical information that will be useful to the audience in general. So I'll launch right in. Key thing to get out of the way first is acknowledgement. And I'd like to acknowledge that the funding was supported by WorkSafe BC and that the Institute for Work and Health operates with the support of the province of Ontario. And then I must say that the views expressed here are mine alone and do not necessarily reflect those of either the province of Ontario or WorkSafe BC. All right, now I can talk freely. So the presentation has three sections, if you will. I'll talk about the research project by setting the stage, giving the context, and then the standard sort of objectives, methods, and results. And I promise not to be too researchy, despite that's my passion. I'll back off a little bit. I'll spend a little bit more time actually talking about the practical guide. I just want to set the stage for how we got to the information in the practical guide, and then I'll come up with a summary. I'm not going to call it recommendations at this point because you'll see that the guide really covers that off. And then this bizarre little equation at the bottom is representing the research project that we're talking about. We're incorporating the evidence-informed or evidence-based approach to coming up with a guide where there's evidence from practitioners, evidence from research, and evidence from stakeholders. And I'll explain that in a little bit more in a moment. So the context. So the Institute for Work and Health is an independent, not-for-profit research organization. Our goal is to protect and improve the health and safety of working people by providing useful, relevant research, either to prevent injuries and illness or to promote recovery or prevent work disability, basically. Our work, we strive to provide impartial, evidence-based guidance to a broad range of stakeholders in occupational health and safety or disability management. I'd just like to acknowledge the research team, a big group of us from IWH, from CAMH, and from Ontario Shores. And I'd like to particularly give a shout out to the stakeholders who were involved in this project. From British Columbia, Alberta, and Ontario, and then nationally, we had Unifor as well. And I want to say that these are not listed here as token. We made the stakeholders work hard in this project. We asked them to ensure that the questions that we were asking workplaces and workers were meaningful, understandable. And then when we got the results, we asked our stakeholders to work with us to craft meaningful messages back. And thereby, I promise to keep this less researchy. We had some people help us not use research language as much as possible throughout this project. And they were very engaged and very helpful in the project. So as you heard Jordan mention, depression in the workplace is a common affecting a large number of Canadians. In 2016, about 3 million were experienced depression annually, and they are often in the prime working ages. And my stats are a little older. We can update that number to 51 billion annually, which I'm sure is the case. We know that workers with depression lose significantly more health-related productive time, have higher rates of absenteeism and disability, and experience higher rates of job turnover. All of this affects the economy and the working lives of people with depression. There are systematic reviews on the effectiveness of approaches that could be used to support workplace accommodations or return to work and reduce associated productivity loss, both from the point of view of looking at return to work practices, but also looking at mental health or depression specific. But the scientific evidence on depression-specific workplace-based interventions so far is not very strong. These are typically difficult studies to conduct. That does not mean that the clinical evidence for treatment of depression is not strong. That's not a type of research I'm talking about here. So despite that level of research evidence, workplaces are coming up with solutions. They're developing and implementing policies and practices related to depression in the workplace to help accommodate the workers that are there. They're not, despite me wanting them to wait for research, they're not waiting for research. So I'm going to pause here for a moment, and I'm going to ask the audience to look at this and just answer in your head what supports and resources are available in your workplace to continue working or to return to work. This is one of the questions that we asked in our survey. Prevention, screening or assessment, non-judgmental listening, information about depression in the workplace, are job modifications available? Is there an employee assistance or an employee and family assistance program available? Are there external resources? Or are you one of the people who might choose there are no supports for depression in my workplace? I'll just ask you to keep that in mind. As I get to the results, you can compare your answers with those of the survey that we conducted. So our research project objectives were to identify the current practices in workplaces for workers experiencing depression. And then create a practical guide to aid workplaces in implementing these strategies. And our purpose was to synthesize evidence from the experience of people in the workplace, managers and practitioners, the research evidence, as well as workers experiencing depression in the workplace. The focus on depression was in part because in parallel with this project, we were conducting a systematic review of the best approaches for workplaces and depression, and our focus was very clearly on depression. Whether or not these expand to a more broader mental health, I think is up to the stakeholders and workplaces to decide. So I won't comment further on that. And so what we did is we reached out and conducted a survey, an online survey, a very short online survey, less than 10 minutes. And then we conducted some interviews and focus groups with all of those people, with workers who experience depression, or managers or occupational health and safety or disability manager practitioners in workplaces who are managing somehow those who are workers with depression. We were guided by the Public Health Agency of Canada in their best practices stages for evidence-based decision-making in coming up with this approach. The questions in all of those methods were a little bit about demographics, very, very brief information, mostly focusing on the experience with depression and what supports, resources, services, or programs were available in workplaces, and what was most helpful of those resources. So before I go into the research project, I'll share a little bit of the findings from the research, from the systematic reviews that we've been doing at the Institute for Work and Health. The research evidence supports the use of cognitive behavioral therapy programs, particularly those with a specific focus on addressing work issues, where the focus of the program is about returning to or staying at work, basically. We also know from the literature that workplace strategies that include 2 of the 3 areas where the workers provided access to health services, where the worker supported by return to work planning and coordination, or where the workplace addresses work modifications along with supervisor training on those modifications, are most effective. There's most levels of evidence for these types of programs from the research literature. So we want to augment that evidence from the research literature by looking at what the best current practices are in workplaces. So we did a survey and got over 450 responses. 2/3 of the responses were from workers, staff or employees who are experiencing depression, and about a quarter were from managers, HR professionals, or occupational health and safety people at the workplace. Most were female, and almost 2/3 were in the 45 and above age range. They were predominantly in permanent full-time jobs. And you can see here that they were from the most of the people that participated in the study were from British Columbia or Ontario. That's partly to do with the funding and where we're located. The other thing I should mention is that the sectors were, or sorry, the respondents were from all sectors. So all sectors are represented, but the highest representation is from healthcare and education, which is probably why we're getting such a high proportion of full-time jobs as well. So we asked a question that I asked you earlier, what services are available to you? And this is the breakdown if you have identified as an employee in our survey. So over 50% indicated that there was employee assistance programs. Around 40% indicated there were external resources available. And unfortunately, around 24% indicated there were no supports available. We also had some information or a number of people who said that non-judgmental listening was available. When we asked, what did you find was most helpful, the picture is similar but changes a little bit in that employee assistance programs, less people found them to be the most helpful. External resources seem to be the type of thing that people found, or the most people found helpful. I do not know how to interpret the no supports available. I think it was just a way to reiterate that there were no supports available. When we asked managers or occupational health and safety people what was offered at their workplace, we get quite a different picture. Here we also see a large number reporting that employee assistance programs were available. We did not ask about external resources because we didn't think that workplace managers necessarily would know about that. So that's why there's no bar there. But we do see that non-judgmental listening, providing information, job modifications, or prevention, assessment, or screening were considered to be available by these the practitioners, if you will, the managers and OHS practitioners. And it's actually not surprising that that would be the response from these people, because this is the kinds of things that they would offer or know about in their workplace. I think what's interesting about this is how different what employees think is available or feel is available versus what workplace managers and occupational health and safety professionals believe is offered. I think that's a key message for this piece. We also asked about what are the barriers to accessing or implementing these kinds of supports for depression. And this is a selection. I didn't give the whole table because it would be difficult to read. But for the most part, what I want to highlight here is that there was a relatively even number of employee responders and manager or OHS responders for most of the categories presented. And just to highlight a couple things, one of the barriers was not sure who was responsible for supporting employees. And so, about 25% reported that. It's important that managers also, the same sort of proportion, reported that, I think. Little knowledge about depression in the workplace. In fact, a higher proportion of managers indicated that response as being a barrier. And then lastly, where there's an item, managers and supervisors not being supportive, and we see a relatively high number of employees endorsing that response, but we also see a relatively high number of managers also supporting that. So we know that there is an issue here in workplaces. This is one of those things that's truly a barrier when you're getting both employees and managers reporting similarly to these kinds of questions. We also asked to rate your workplace on a 1 to 5 scale, where 1 was no strategy and 5 equals excellent. And you may not be surprised to know that for the most part, the highest proportion of employees rated their workplaces as poor, whereas most of the managers or OHS professionals rated their workplaces as good. Now, it's very important for me to point out that these are not necessarily people in the same workplaces. So it's quite possible that this is the way the picture looks. It's also not surprising when we do research in workplaces, usually get a higher opinion about occupational health and safety strategies from managers and occupational health and safety professionals than you do from workers. So not surprising, but not a great result to see this difference in experience between those who work with depression and those who manage workers with depression. We also conducted interviews and focus groups to get more in-depth information about what was available and what worked. And now, in order to do this, we used a subset of the survey participants, which allowed us to keep things relatively even. So we have an even split between Ontario and British Columbia. We also have an even split between employees and individuals in managing roles. There were 5 main themes that emerged from the data in the interview and focus groups. These themes, we labeled them. One was very simply labeled lack of awareness and psychological hazards. And this reflected that people is almost the opposite of the next theme, which is supportive workplace culture. People felt that there were workplaces where they were not very aware about mental health, and that there were psychological hazards in the workplace that aided to the problems with depression and mental health. On the flip side, another theme was one where a supportive workplace culture was highlighted, where there was awareness and communication was available. Another theme that emerged was around flexible approaches. This was probably the most predominant theme, the need for individualized and flexible approaches to accommodations and resources for depression and mental health in the workplace. The last 2 themes were mostly about communication. So communication was important, and it runs through all of these themes to some degree. But what came out was that there was communication about process, about how to go off work if I needed to, or how to get accommodations. So it was a lot about not just communication in general, but very specific about the kinds of processes that are available in the workplace to get accommodation or move through the stages if you're a worker suffering from depression. And then last theme was about coordination with external resources. And I have to say this surprised us, both the researchers and the stakeholders on the team, in that we hadn't heard much about this in the literature. And what was really coming out of this one was there was desire from employees who were experiencing depression to have the workplace involved and understand what resources might be available to them outside of the workplace, and help them coordinate with those external resources. So that could be simply getting to a GP or a family doctor, or all the way to peer support groups or other community-based resources, which emerged as something that was quite important in the course of this research study. And so just to highlight a couple of those things, communication about process, just a short representative quote: the return to work check-in process should stretch 6 to 9 months into the future. And then around flexible approaches, we heard very often, multiple forms of support and lots of latitude are important to help keep people at work. And so we have some balance between the quotes from managers and employees in this as well. So I promise not to get too researchy, and I'm going to stop talking about the research now and switch to the practical guide. So our approach then was to take the themes that emerged and the data from the survey and come up with a guide that built upon these 3 sources of evidence, which is, I must say at this point, this is the original definition of evidence-based medicine from David Sackett in the early 90s. It never was that only research was the sources of evidence. And you might ask, why did a bunch of researchers want to create a practical guide? Well, we did a little bit of a resource scan, and there are lots of wonderful resources available for mental health and depression for workers, for going back to work, for staying at work. But many of those resources don't talk about implementing or how to implement these supports and things in the workplace. So we thought there was a bit of a gap there. And so we tried to focus on a little bit on the implementation side. We also didn't determine that many that spoke directly about where the evidence came from. So while they looked like very good resources, there wasn't a very strong connection to where that evidence came from. So our guide was to have the content from these 3 evidence sources and be very explicit about those evidence sources. We kept things in positive, action-oriented language. We used illustrative case studies that emerged from the data that we collected, both from the interviews and focus groups as well as the survey. And the focus really is on implementation. How do you put this in place in a workplace? How do you put these kinds of programs? How can you be creative about including these programs or practices in the workplace? So we used little icons. We called it an implementation tip, and they're sprinkled throughout the guide. We used icons as well to highlight who might be most interested in particular messages that we've given. And I'll show an example of how this works. But our legend is there showing the 5 different parties that we highlighted in the course of the guide. The guide has 3 main sections, and you'll see that this emerged primarily from the qualitative, the themes that emerge. So there's a workplace culture section, a workplace processes section, and a workplace and non-workplace resources section. And then I'll just highlight a few points for each of these sections, just to show what the guide looks like and the kinds of information that we're sharing with this guide. So in the workplace culture, there's one aspect that was genuine and caring communication. So the idea there is that we'd explain what this was, and then provide the data or the evidence from the data that we've collected, either from research or from the study that I just spoke about, and then target the party that might best hear this particular message. So you can see that in the middle of the slide, there's a union and manager, established relationships in which genuine and caring communication is the norm. And we take as much of that information from the evidence and provide it in these bullets. So here we also have an implementation tip. Do not wait until a worker is taking time off work or returning to work to express genuine care for their well-being in the workplace. And this is a story that we've heard throughout our research about how, it wasn't until I was off work until somebody said they cared at all about what was happening to me. So this was a common aspect of the themes that emerge, and it really is about communication in general. So another part of the way we've set up the guide is to include case studies. The case studies also emerged from the data that we collected, particularly from the interviews and the focus groups. I won't read this entire case study at all, but this was really about a manager noticing that a worker has not been herself and just mentioning that. And in mentioning that, prompted the worker to think about what other steps that she would take. She wasn't looking to come to get anything back from the workplace, but just that conversation sparked an opportunity to look into how she might deal with either depression or mental health or whatever in this case. Another guide section was about workplace processes. And then what I'll highlight here is about planning and facilitating return to work. So the examples here are, again, we explain what the return to work procedure might be. And here you can see how the icons target a lot more of the individuals in workplaces. So We have worker, union, manager, and HR, a message that may resonate with all of those people. An individualized, gradual return to work plan may aid in a successful return. Consider accommodation needs, job duties, and think creatively about how to help resolve conflicting demands. That think creatively part emerged very strongly, and the workplace parties, the managers and occupational health and safety people, relayed to us a number of very creative approaches where they went above and beyond, I think, in some instances. Another bullet that I will read here because it resonates and was a very common thing is the middle bullet, coworker and union. If a coworker is returning to work after being off for a period of time, you need not know the reasons for the absence in order to welcome back. Simply saying welcome back with a smile may help. And this was a very common piece of information that came out of the interviews. And a lot of times this was also contrasted with the difference in how physical injuries might be addressed. So a lot of the stories that we heard were about if somebody had a broken leg or a broken arm and they came back to work with a cast on, they were brave for coming back to work. They were, going above and beyond. Whereas if you were struggling and coming back with a mental health issue or depression, it wasn't the same. There wasn't the same welcome back. There wasn't the same thought about being brave or and needing the same kinds of support by saying welcome back and ready to get back to your job. So that was a common thing that we heard. And again, a case study, in this instance, the case study was about going off to work. And again, I won't read it all, but the interesting thing about this was one example of a creative approach. So at the very end of this case study, when there's a return to work meeting set up by a manager and the HR person, the worker would have a meeting then, but the manager has an idea, which was to pair the worker with another worker who had successfully returned to work after experiencing severe postpartum depression. That worker had previously expressed interest in mentoring other workers, and so she wanted to propose this in the return to work meeting. So this is again an example of some creativity, and the need for that creativity and flexibility was apparent all the way through this particular research study. And the last section I'll just touch on is the workplace and non-workplace resources. And here I'll just touch briefly on both the employee assistance programs and the non-workplace resources. There's a case study that we included in this section about EAPs, which was just the fact that it was a reminder. So having a worker who had been recently diagnosed with depression and hoped to continue to work, but was having some challenges with the medications and was not able to see a psychiatrist or psychologist in a regular or at least was on a waiting list. And this is also something that we heard a great deal about. It was this, the delay in getting appropriate treatments outside of the workplaces was a very, very common thing. So this case study is about the reminder. The HR manager had been reminding people through emails, articles, notices, and the case study shows that just by seeing one of these notices, a worker was able to get some counseling sessions, which gave him, while he was on the waiting list, to see the psychiatrist, basically. And this is a story, basically just as is, that we heard a number of times, the challenge of getting to see somebody for treatment, but the delays in getting started with that, and then looking for resources to bridge that gap, if you will. And then non-workplace resources, which again, I mentioned at the beginning, was a bit of a surprise how often this was mentioned, but people mentioned needing support from a whole host of rehabilitation professionals, their own physicians, other health providers, family members, and community. Community was raised quite a number of times. So here we have an example of providing a research finding. Cognitive behavioral therapy, especially if work-focused, can help you remain at work or return to work when experiencing depression. And then this other bullet that we've targeted to union managers and HR, but maybe all workers should know about this. Be aware of the resources available in your community so you can let workers know about potential support options. This was a very strong recommendation that having that kind of support from your workplace was so important to workers with depression, because they are feeling like they don't have their own resources to find these things. They don't have the energy sometimes. And so having the workplace help with that was so meaningful to them. And again, just an example of an implementation tip here. So that is a broad view with some selected pieces of the guide. There are more pieces that I skipped over, but I'll summarize now, and then we can try to open things up for questions, which I'm happy to take. So our research synthesized evidence from 3 sources: the scientific literature, practitioner expertise, those managers, occupational health and safety or disability management, people in the workplace, and worker experience. We based it on the original definition of evidence-based, and we used a method by the Public Health Agency of Canada to guide best practices approaches. And that's what we used to create the guide, if you will. So we synthesized practice and scientific evidence to help guide the policies and practices to support workers with depression. And the idea, again, was not just to provide those resources in a guide, but to talk about how that might be implemented in a workplace. We tried to go that extra step, if you will. And in summary then, the study results reveal the importance of 3 types of supports: non-judgmental listening or genuine and caring communication, flexible individualized supports, and external treatment or support resources, both from CBT programs, but also just knowing about what's available in the community. So this is a blend of the different types of evidence that you're seeing. So that came out very strong. And to this, I added another 3 bullets. So we're going to try to keep you with the 3 and 3 thing here, but implementation, the facilitators and barriers that emerged from this project showed that culture, particularly the awareness of mental health, and the opportunity to be open about it. So that was the big thing about workplace culture: being aware and having open communication, or the opportunity for open communication. The second facilitator or barrier, depending on which way it goes, is the communication about process. Obviously, it's a facilitator if there's a good communication level about the processes available in workplaces to accommodate and or to go off work or return to work. And lastly, the biggest barrier that was mentioned was not knowing who was responsible and not having the knowledge necessarily to accommodate workers with depression or mental health issues in general. So I've listed these as facilitators / barriers because, of course, on the positive side, they would be facilitators. If they're not present, then they would be barriers. So that concludes the presentation about the research and the guide. The guide is freely available on our website for download. It is one of the more popular tools that we offer at the Institute for Work and Health. This link will be in the slides that will be provided afterwards. And I will open it up to questions, but just before I do that, I'll mention, if you are interested in prevention broadly, think about Safety 2020 Canada. and that website. And if you have any other tools and evidence-based practices needs, please check our website out. And I'll stop there. Thank you.
Fantastic. Thank you, Dwayne. This is the first I've actually heard of this research project and this guide, and I am incredibly excited to take a deeper look at it, especially since, as I think you mentioned, it takes a wider view of what evidence is and really does synthesize the experience of employees working with depression, along with what we know to be evidence-based from academic literature. So this is really exciting.
Thank you.
Yeah, we've got a couple questions from the audience, and I'm filtering through these right now. But one that I wanted to start with, because I think this is quite fundamental. You touched on this idea that what employees really want, or one thing that they indicated they want, is for their employer to be able to understand and direct them to resources available within the community. And this is a conversation that at CMHA we have with employers all the time. And some of the concern that often comes up is just around managers or HR professionals not really feeling that traditionally this has been a part of their job. So when you discuss that reality with HR or managers or OHS, did you get any of that concern coming up, or maybe even that just a general lack of awareness of what's even out there?
Yeah, we did in fact get that kind of response, but most of the time, and I think this may be part and parcel with who decided to answer the question. It seems like the managers that we were able to either talk to or answer the survey were the ones who were trying hard. So we're getting that perhaps more positive group of people who've been trying to do this. But we did get that kind of hesitancy about this is beyond. But that was generally speaking what managers talked about. They felt they needed more training. They would like to do a better job. They felt they needed more training on not just understanding what to look for and how to help, but really on how to communicate effectively. And that was something that came out of the discussions, especially in the focus groups, where managers would talk to each other and say, yeah, if only, like, and when we think about how managers sometimes get to their position, it's not because they're trained well on communication, it's because they know the job very well. So sometimes that is a barrier, and we got that a lot, the managers wishing they could do a better job.
Yeah, that makes a lot of sense and parallels a lot of what I've heard as well anecdotally, and that the skill set of managers in supporting employees experiencing mental health conditions, depression or others, is different than what might typically get someone into a management position. There's a lot of those quote unquote soft skills that we're realizing now aren't actually that soft and are in fact very concrete and shown to make a huge impact. Well, thank you. So I'm going to jump along to another question that we had someone ask, and this is around the issue of disclosure. And not sure how much you touched on this specifically in your research, and maybe you got at it tangentially, but we have one of our participants asking, do employees living with depression often disclose their condition? And if so, does that disclosure tend to have an adverse impact on their job?
So we did not directly ask or really talk about disclosure. It did emerge sometimes in the discussions around communication, and some of the workers indicated that they having disclosed that cost them sometimes, but other employees would talk about disclosure and how it freed them and it actually got them to places where they had resources. So I should emphasize again, we did not focus on disclosure. We actually have an ongoing project now with a bigger group at IWH where we're looking very explicitly at disclosure, both the challenges and benefits thereof. So yeah, I can't answer directly other than there were experiences on both sides of the coin, if you will, expressed in the data.
And I think likely a very personal decision too, right? That's sort of weighing pros and cons in the context of an individual situation and the individual's work environment as well.
Yeah, very much so. And I think that's one of the things that maybe I should circle back to is that many of the resources that were available when we did our scan really were about individuals. So coping, resilience, very much worker focused, what the worker should be doing. And less of the resources that we saw were this, both workplace and worker. And there was a real understanding from some of the participants that both parties need to be involved somewhat equally.
Right.
Some workers even saying that, they first thought, well, no, I don't need to tell them anything, and I don't need to be involved in this. The workplace has to help me. And then later on realizing, no, I have a role to play in this. So there is something to do with coping and resilience, but it shouldn't be only the worker that's doing all this. And that came out pretty clearly as well.
Yeah, resilience is occasionally framed as this individual quality that takes a lot of the responsibility away from the workplace and the employer. I think what you've just said really articulates the fact that this does need to be this does need to go both ways, and there's a role for both sides to play in successfully supporting someone experiencing depression in the workplace. So moving on to another question then. To your knowledge, you've proposed a lot of really practical strategies. I guess the question from the audience is, do you have a sense of have these specific strategies been implemented in workplaces? Are they effective? And was there any, or did you do any follow-up with organizations after your research to understand if they'd utilized some of these strategies from your guide and if they'd had some success with them?
So short answer, no, we have not been able to follow, but that is a question after my own heart. That is exactly where I'd like to go next with our research. My latest area of research is really about implementation, about the challenges of how to get practices in workplaces to do this kind of either accommodation or prevention work. And I'm extremely interested in doing that. So I'm open for funding to do that exact kind of research.
That sounds like fun research to me, and also challenging. I think when you think about some of these really concrete strategies that your guide highlights, in particular, having supportive conversations, right?
Right.
That's a difficult thing to define, and also can be a very difficult thing to measure in isolation, right?
Yes.
But I can see the value in understanding the direct impact. So then if we then shift our focus to saying, okay, well, we haven't yet got to the point where we're looking at each of these specific strategies and how they're implemented and their effect. In your opinion, if we look at the barriers, do you have a sense of how some of those barriers can be minimized? I think you identified at least 6 different either barriers or facilitators. So what can employers or employees for that matter do to help minimize the impact of some of those barriers?
So from the research project, what seemed to be the key thing there was this open lines of communication. The starting point had to be that there was an opportunity to communicate that this is real, this is a problem. There was a lot of there is still a lot of stigma associated with mental health and depression, and some workers indicated that they didn't feel comfortable talking to anybody in their workplace because it felt like that they would continue to be isolated. So that seemed to be the first important part. So management support of the opportunity to communicate was often mentioned as one of the first steps in the experiences that we heard from. But that can't be enforced is one of the key things that we also heard, and that is, so people have to be open to hearing this and open to finding out how they can work within a system like that within a workplace. So the organization itself needs to be open to that kind of change as well, not just the organization, but the individuals within it. So I would say that's the first and important step. One of the quotes was, "We don't just do it, we live it." The idea that, you know, that management was very supportive of their workers and of the programs, and that seemed to be the way to break down some of those barriers.
Mm-hmm. Yeah, and trying to make it as much of a common element of your role and your day as possible, I would assume.
I would say too that what a little bit, not specifically from this research project, but subsequent to it, that the psychological standard and some evidence that suggests it's being implemented more broadly across Canada does seem to be making a difference in that respect. So that has brought awareness to a level at many organizations. So that's been somewhat helpful, I'd say.
Mm-hmm. Yeah, and from the perspective of Canada's national standard, I mean, much of what you've addressed is articulated in some of those risk factors, right? Clear roles and responsibilities, involvement and influence in how decisions are made, effective workload management, and then primarily this idea of psychological and social support within the context of the workplace are explicitly listed as some risk factors, or on the flip side, facilitators to a psychologically safe workplace.
Right, yeah.
So I guess so there's tons of questions here, which is great. I'm just trying to sort through them. Someone has asked, in your opinion, are employers by and large open to implementing some of these suggested strategies in their organizations? And if so, or if not, maybe what can help promote the awareness that these strategies are actually beneficial for their companies?
I think from what I heard in the research now, so here's the limitation of the research. So when we put this call out, you get the people who are interested who will answer your survey. So it seems to me like we got a representation of managers and workplaces who were interested in helping their employees. And so even the barriers mentioned were historical and many times stories about how those were overcome. The evidence recently from the psychological standard suggests that people are moving to overcome the barriers. But I don't have an opinion. I guess what I've noticed is, and I'm old enough to know about the RSI scare in the early 90s. Musculoskeletal disorders were not well understood. Nobody understood. They're relatively invisible. Some people got them and their coworker right beside them doing the same job didn't. It took a while for workplaces to realize that there was something going on at workplaces, but they did come around, and now most places have very have pretty good policies about musculoskeletal disorders. It's not like it's gone, but it's there. The trend that I'm seeing with the psychological standard and its implementation, and hearing some of the workplaces that have overcome barriers, suggests to me that it's moving in the right direction. I do think that the stigma and the challenges of having open communication may make this a little bit more challenging, but it does seem to be moving in the right direction.
Mhm.
That's my
And
glass half full.
I like it. I'm a glass half full guy myself, and from where I stand, I would say something very similar in that there's a huge coalition of the willing, so to speak, across corporate Canada that are starting to do this really well, and most of them are aligning with Canada's national standard. I think that there's a lot more to do in terms of convincing other organizations that maybe aren't attuned to this need yet, that some of the solutions are actually fairly concrete and straightforward.
Right.
So I think there's a lot more work to do to make sure that organizations are aware that these solutions exist. And so I guess building on that, and this feeds into a couple different questions from the audience. So, looking ahead, how do you want to build on this piece of research, and what's next in terms of questions to answer, and what the Institute for Work and Health is going to be undertaking?
So we have an ongoing research project now that's looking at disclosure, and we're actually looking at how we might contribute to resources about disclosure in the workplace, because that aspect of communication is important and is challenging for workers, particularly I think with mental health and in the environments sometimes that they're in. The other thing that I've been doing and working towards is to have a better understanding of what implementing programs and policies in workplaces really entails. And surprisingly, there's not a lot of research about that out there. What we know about from implementation usually is from healthcare services, implementing evidence-based care programs, and there's lots of models there, but there's a lot less taking that into the workplaces. So I've been looking at some models that are about implementing community health, and trying to tailor that to try to figure out how to look at that within the workplace. So what would be, for me, having come up with this particular methodology would be easy to take it one step further. It would be easy to reach out to people who are trying, and then look at the key implementation steps and find out if those are being reached. Which mirrors in some ways the report recently about the implementation of the psychological standard as well. So building on the Public Health Agency of Canada, and then having a better model for what implementation means in workplaces. And as I say this, I am fully aware that implementation is not a word that's often used in workplaces. They're putting programs and practices into place. But researchers, we continue to use the word implementation. So please excuse me for that, for all of you practitioners out there.
Happy to excuse a little bit of research jargon here and there, Dwayne. From my perspective as well, I would look forward to seeing some research on that in particular, because from our perspective at CMHA, we support a lot of workplaces in the quote unquote implementation of programs, training, education within their work setting. So I would love to get a little bit more specific about what implementation processes work best within the workplace. So when that research is in a form that's ready to present, I know I would certainly look forward to seeing it.
Great, thank you.
So we've got just about at the end of our time, actually. So I guess the last question I have is really just to bring it down to that really concrete practitioner level here for any managers on the call, or HR professionals or OHS professionals. If you can lay it out really simply, what's one thing these professionals should start doing tomorrow to better support employees working with depression? And what's one thing they should stop doing tomorrow?
Well, I think the key thing is to engage in genuine listening. Non-judgmental listening seems to be, again, one of the first steps. And become as educated as you can about mental health. I think that barrier that both employees and managers mentioned was a key to a lot of the other broader barriers that we saw, and led to this whole idea of, just learning a little bit about what's available in your community and being able to help somebody without needing to have disclosure, maybe, point them in the right directions. It's that first level of non-judgmental listening. And I guess it really is simply the flip side. Sorry, I was trying to process the other side of it, but it really is the flip side of that, which is, don't dismiss this. Just because you don't understand it, can't see it, does not mean that it's not a real condition. And many of the stories that we hear about depression, especially in the more severe forms, is that the workplace is the last thing to go. Many people have lost their family and their friends, and are struggling just to maintain their job because that's their livelihood. So sometimes that is the very last thing to be affected. So it's important to have that non-judgmental listening.
Well, thank you, Dwayne. I don't see any better place to leave it than right there. So thank you so much, and we'll turn it back over to Yusra for any final comments or details.
Thank you both so very much for your time. Dwayne, thank you so much for teaching us about your research and the workplace strategies to support employees with depression. And thank you for presenting another webinar coming up on Friday, November 22nd at 11 a.m. Pacific time, 2 p.m. Eastern time, titled Implications of an Aging Workforce, Work Injury, Recovery, Returning to Work, and Retaining at Work. We're looking forward to your insights on the returning to work and retaining of the aging workforce. And Jordan, thank you so much for accepting to moderate the webinar and for your valuable input. So thank you both very much. And to our audience, thank you for joining us in this very compelling webinar.